Welcome one and all to our Sunday Critical Care webinars, Young and Young Intensivist. So today we have a case presentation from Dr. Soren Panja's ICU. Sir is Head of Critical Care at Ravindranath Cardiac Center, Kolkata. And the case will be presented by Dr. Devkamal Mukherjee. He is Associate Consultant at CK Birla Hospital, Kolkata. Earlier he was with Dr. Panja. Now he has cleared his DNB and he's associate consultant. And later on, the cardiologist who was involved with this may also join us. He is Dr. Aryan Kar. So I think without further ado, I will hand it over to Dr. Devkamal. Dr. Devkamal, please start proceedings.
Okay. So is my screen visible, sir?
Screen is not yet visible.
Okay. So is it visible now?
Yes.
Okay. So good evening, everybody. Thank you, Dr. Tapas, for this wonderful opportunity to present this kind of a case in this forum. Let me start. We had this patient who was a 42-year-old male. He was businessman, resident of Kolkata. He was an active smoker, and he was hypertensive on 5 milligrams of amlodipine daily. This patient presented to our emergency department with history of chest pain radiating to his left arm for last 10 hours. He was very short of breath for last 1 hour, and he was profusely sweating for last 30 minutes. So with these kind of presentation, basically the differential diagnosis which comes to our mind right at the onset is that of acute coronary syndrome. So because this is a very common presentation which usually we come across in our emergency department, and along with that, we also should keep in mind of other probabilities like acute pulmonary embolism, aortic dissection, myocarditis, and other causes like abdominal causes with gastritis, peptic ulcer, esophageal rupture, and all those things, and the lung causes like tension pneumothorax or pneumothorax should be also kept in mind. To complete the list, we should also get a complete drug history from the patient itself. So these are the two differential diagnoses to complete the list which we should have in our mind before going to patient. So
Dr. Devkamal, what is you have given the differential for chest pain. Just go back to that. What is the
here
for you? What differential diagnosis?
Pardon, sir, I couldn't get you, sir.
So you have given the differential diagnosis for chest pain, huh? Acute chest pain.
Yes, sir. Yes.
So what do you think is the differential here? One can be acute coronary syndrome.
Yes, sir. Well, acute coronary syndrome, pulmonary embolism may be a differential. Along with that, we have to rule out aortic dissection. Though the chest pain which the patient was complaining that he is having a central one, he could not localize it, and it was radiating to his left arm, which is very much typical of acute coronary syndrome. Along with that, since he was starting to have respiratory distress, we should also think about the lung causes like pneumothorax, or there was no history of trauma or something like that, no history of fever. So pneumonia could be ruled out, means it could come on the differential's latter part. Okay. So the primary thing which we had to exclude is number 1, coronary syndrome, number 2, pulmonary embolism, number 3, aortic dissection, and other causes like the abdominal causes like an esophageal rupture or something of that sort has to be ruled out, because these are dire emergencies, right? So we have to take appropriate steps.
That is very good. And myocarditis also would have to be considered. Short.
Yes, sir. Yes, sir. Definitely.
Myocarditis can cause chest pain, and other thing is aortic dissection is, like you said, very important here. And aortic dissection pain actually radiates typically to the back also,
To the back, exactly.
and it is associated with MI also. It can cause MI itself, aortic dissection.
Yes, sir.
And
Yes, sir.
pneumonia, by virtue of causing pleuritis, can cause chest pain. Normally, it would not cause chest pain. But like you said, history is not consistent with pneumonia, no fever, no cough, and very short history. So
Yes.
that is the differential diagnosis for this. One must always consider, am I in any pain from the occiput to the umbilicus? That is a
Yes,
general
that is a dictum.
manifestation of coronary pain. It can occur up to the abdomen in the umbilicus, and sometimes you miss it because the pain is in the abdomen, and nobody thinks of acute coronary syndrome.
Syndrome, exactly.
That has to be kept in mind. Very good, Dr.
Yes.
Dev. Carry on.
So coming to the physical examination of this patient was confused right at the onset. He was having a cold, wet peripheries. His pulse was he was tachycardic. His pulse was 110 per minute. The volume of the pulse was on the lower side. It was regular. His BP was 98 by 50 millimeters of mercury. He was tachypneic, breathing at a rate of 30 per minute, saturating around 88% with 6 liters of oxygen via face mask. His JVP was found to be raised, and on auscultation, we found basal crepitations bilaterally.
So now, Dr. Devkor, what is the diagnosis? Does it narrow down?
Yes, sir, definitely. This patient is having tachycardia, tachypnea, along with raised JVP with bilateral creps, which is suggestive of a heart failure. So it is much more pointing towards a cardiac ailment rather than lung cause, because the patient is having high JVP. The patient is having cold, clammy extremities. He is confused. There is evidence of uh, organ dysfunction because he is having an altered mental status. His peripheries are cold, his JVP is raised, there is basal crepitations. So it is pointing towards a cardiac cause.
What
With
finding
a
in this rules out
associate.
pulmonary embolism? What finding in your examination rules out pulmonary embolism?
So, in case of pulmonary embolism, the patient will this basal crepitations means there will be the on auscultation there won't be any findings, right?
Yes,
But
very
in
good. So basal crepitation meaning here is left ventricular failure.
failure,
You
definitely
ruled out of pneumonia. Huh? Pneumonia you can get, but pneumonia is not likely here. So basal crepitation is a pointer towards left ventricular failure.
failure. Exactly, sir. Exactly.
One thing is there here, Dr. Devkamal, you have mentioned low volume pulse.
Yes, sir. Yes, sir.
The pressure is 98 by 50.
Uh,
Does
Sir,
that fit
this
in with the
is
low volume pulse?
the pulse pressure over here is around 48, sir. But actually, it is a very subjective thing
Yes,
to
okay, I
decide
agree
about
with
the.
you. This may have been done by someone I may have just mentioned like that, but low
Yes,
pulse actually relates to pulse pressure, and to have a low volume pulse, the pulse pressure should be less than 30, and
yes, exactly, sir.
low stroke volume. So that is
Yes.
very important. These discrepancies should not be there when we are doing an examination, especially in a cardiac case. So this is very important. Now,
Okay, sir.
just
Okay.
like Dr. Panja sir, your comments on this. The diastolic pressure is 50 in a patient who's supposed to be having some kind of a cardiac failure. So that is a low diastolic pressure, which we normally do not see with these patients. You know, the diastolic pressure is normally higher. This indicates more like septic shock or diastolic pressure of 50. So, sir, your comments on what kind of a pressure we are dealing with, 98 by 50, you know?
Actually, that depends on your actually whether patient is in a compensated state or sometimes in a decompensated state. So if a patient is in a decompensated state, so that time you might have that diastolic pressure. Sometimes you may get little higher, but sometimes because of the patient in acute coronary syndrome, sometimes it sometimes behave like your kind of hyperinflammatory state also, because there is after AMI or any kind of the insult, okay, particularly acute coronary syndrome, it behaves like because of the inflammatory mediators that come down in the system. So that sometimes dilate your blood vessels.
So
And
that
not
is,
only
I think,
that, and
Dr. Panja has hit the nail on the head. One must realize that cardiogenic shock after 10, 12 hours can have a systemic inflammatory response syndrome. It behaves like a,
yeah,
in some patients, it can have a systemic inflammatory response syndrome. That is why the diastolic pressure may be low, one reason. The second reason, if there is advanced atherosclerosis, the diastolic pressure does go down. In a patient who has
yeah,
atherosclerosis, the systolic pressure starts going up and diastolic pressure starts going down. Because if you have noticed, classically elderly patients, hypertensive, atherosclerotic, they have blood pressures like 160 by 60, etc. If you do them routine. So that may be another reason. And the other reason is the blood pressure is 98 systolic. And he's cold, wet peripheries, and he's confused. So, Dr. Devkamal, why is he confused?
Sir, see, this patient is a known hypertensive. Okay, we don't know how much control of hypertension he had in the background. Okay, sir. So, though the BP seems to be 98 by 50, it seems to be a normal, but for him, maybe it is on the lower side. That's why his organ perfusions are getting deranged. So that's why he is confused. So
Very good. So, this is a case of relative hypotension. In patients who are hypertensive, you do not have to have a systolic less than 90. Somewhat elevated blood pressure is also consistent with a shock state. So, looking at
yes, exactly.
the patient seems to be in some kind of cardiogenic shock. Though, of
Yes,
course,
sir.
definition of cardiogenic shock means hemodynamic indices, that is a cardiac index of less than 1.8 and a elevated pulmonary capillary wedge pressure more than 50.
Wedge pressure.
Evidence of low perfusion and systolic pressure of less than 80. So those are the components of a cardiogenic shock. But clinically, we can say that he is in some kind of a cardiogenic shock with low perfusion state, low blood pressure, and left ventricular failure. Carry on.
So the next step which we did in our ER was to get an ECG done for this patient. So this was the ECG rhythm strip which was recorded. It showed ST elevation in V1, V2, V3, and V4 with presence of pathological Q wave. T was inverted, and this ECG clinched our diagnosis. This patient was suffering from an acute anterior wall myocardial infarction. So we did this ECG within the first 10 minutes of his arrival to our ER, and which clinched our diagnosis. And then we got forward into the further assessment and management of this case.
Is there any differential for this, Devkamal, with the ST elevation and cardiac failure?
ST elevation along with cardiac failure, sir. If the this ST elevation is only in the anterior leads, if the ST elevation is all throughout, then pericarditis may be thought of. But and along with that, there may be presence of any ventricular aneurysm. That time also, patient may have an ST segment elevation. So
ventricular aneurysm will actually develop later, but you have very rightly said pericarditis is the differential here. Pain of pericarditis can mimic pain of acute coronary syndrome, and it can have ST elevation, but the ST elevation is not conformed to any territory. It is a kind of a ST elevation, and the nature of the ST elevation is also different compared from MI. PR segment changes also in pericarditis. So pericarditis per se will not lead to cardiac failure, but if it goes into tamponade, then you can have congestive cardiac failure. So that is one differential we can always consider in this.
Yes.
Then one question here is, did you do right-sided leads?
So for this patient, we didn't do right-sided leads because right-sided AMI is usually associated with inferior wall involvement. Okay, so or a RCA involvement. But this typical picture was suggestive of a LAD involvement because the precordial leads were involved. The lateral in 1 AVL or in 2-3 AVF, there wasn't much of a change. So we didn't go for a
Yes, that is true. Most of the time it is associated with inferior wall MI, but nonetheless, for sake of completeness, one should do right-sided leads. And the JVP was elevated. So you see, you have said the JVP was elevated.
yes, sir. Yes, sir.
Towards right ventricular involvement, because in acute MI, within the first few hours, the JVP does not elevate because the pulmonary vascular capacity is such the capacitance accommodates the extra volume which is backwardly transmitted from the LA. So the classic the JVP does not elevate initially in acute left ventricular failure due to MI. So for the sake of completeness also one should do right-sided leads. Sometimes you may miss, and then if there's hypotension, if there's right ventricular infarction, it can respond to fluids in the appropriate.
Yes, exactly.
Okay, carry on. The one question, Dr. Sanjay sir, you like to tell how to see the JVP, because the JVP they have seen, and for the students how to see the JVP.
Yeah, Dr. Bansal, what I got, you want to mean how to see the JVP? No?
Yeah, for the students' sake, how to see the JVP in our ICUs. Sometimes it is a helpful marker. All the time CVP is not there and all that. So for the students, if you can tell how to see the JVP.
So JVP is basically you have to the proper positioning of the patient is very important, because you can make your patient positioned at around 45 degree, or sometimes sitting also it is here. If you have to first you can start with sitting. So if already you can see the upper level of the ear, you may not see. So then you recline to 45 degree. But if you see even in the sitting posture 90 degree when the patient is sitting, so if you can see the upper level of the JVP, so how can you see? You should see it tangentially. So if you are looking from the right side, for the right side JVP, your eyes should be tangentially look at the neck. And it sometimes what I have seen, people are basically the students sometimes see in a vertical, yes, so you may just missed it. So that is one thing. And then in the sitting posture, if you see tangentially that the neck vein is means basically you can see the upper border of the neck vein. So then you can see that the neck vein is raised. So that time you can roughly assess what is the vertical distance from your sternal angle to this distance. But if you cannot see, gradually recline the to 45 degree. Even in the 45 degree, you may see, or if the JVP is really elevated. But if it is not at all elevated, so then you cannot see it. So once you can see it, then try to characterize it. Means basically you have to differentiate between the pulsation, whether it is venous pulsation or pulsation. So that differentiation you can make it by seeing the characteristic of the wave, as well as whether you can basically abolish that wave by putting small pressure at the base of the neck. So that is it. And if you have a doubt, so then you can also coincide with the auscultation. Okay, simultaneously you can see the auscultation of the heart as well as you look at the neck vein. So whether you can be sure that this one is neck vein or not. The typical characteristic, as there will be 3 peak wave, that is C, and in between there will be A, C, and B. So characteristic wave is a defined type, undulating type, and arterial pulsation is a very upstroke type of pulsation. So from that character you can see, and then after that you can also from the neck vein. So how is the character of these waves of A, C, B waves? So from that you can judge that whether your patient is having any other valvular abnormality or the right side, if that like your tricuspid regurgitation is there or not, or sometimes even if there is tamponade, that may happen in some cases. So tamponade or sometimes constrictive pericarditis. So these are the things that you can easily, or if you are very good in your clinical cardiology, so from neck veins you can judge. And because this one is one AMI, and if there is, so suppose this ECG is normal, sometimes conduction abnormality, particularly if there is a complete 3rd degree AV dissociation, that sometimes also may be picked up from the neck veins, because there will be sometimes cannon wave, and that will be very characteristic that you may pick up. But because this ECG is not showing any type of this rhythm is very much sinus, so I will not come. But these are the something that you can pick up from the neck veins.
So very nicely said, Dr. Panja. I will just briefly summarize that. First of all, if in the sitting position you see the JVP, it means it is elevated. If you are not seeing any JVP, does not mean that the JVP is not elevated. This is true for obese necks and necks with thick muscular walls. JVP pulsation sometimes gets hidden behind the fatty tissue and the thick muscular walls. Third, if the neck veins are grossly distended, that may be even external jugular veins, then the JVP is elevated. Fourth, you put the patient at 30 to 45 degrees, like sir has said, and normally the JVP upper level is around 4 centimeter above the clavicle. If it's going beyond that, that means the JVP is elevated. Just to put all these things simply, like sir has said. So JVP is a useful tool. Sometimes the CVP is not there, or you cannot estimate the volume status or the right heart status. You can always use the JVP. So that is about the JVP. Carry on. Other question, Dr. Devkamal. Can the ECG be normal in cases of acute myocardial infarction?
Yes, sir, definitely it can be, because actually there is in acute coronary syndrome, it comprises of three different entities, right? One is STEMI, which we are dealing with right now. Another is NSTEMI, or non-ST elevation myocardial infarction, where there may be ECG changes of ischemia, like ST depression or T wave inversion in respective leads. And along with that, there is an entity which is called unstable angina. So this NSTEMI and unstable angina, for these two categories of acute coronary syndrome, the ECG can be normal. If there is evidence of increase in cardiac biomarkers, at that point of time, we may say that this patient is having an NSTEMI with a normal ECG. And along with that, if the patient is having a typical presentation of the chest pain, which is very much suggestive of myocardial ischemia. So with that, a normal ECG can be a finding. If the patient's presents too early, there may be, means these ECG changes may need some amount of time to get developed. Like the patient may present with just tall peaked T waves as a finding on the ECG in the initial part. So basically, the patient may present with a normal ECG, but still have acute coronary syndrome.
Yes. So 5% of STEMI have a normal, for 5% of supposed STME have a normal ECG. And this is because of transient elevations or evolving MI, or because of posterior nature of the MI. And these patients have a good prognosis when they do not have ST elevation. And of course, like you said, non-STEMI kind of a presentation, that is unstable angina or non-STEMI, can have normal ECGs to a much greater extent. Definitely. Very good. Carry on, please.
So as we had discussed earlier, so this acute coronary syndrome comprises of three different entities: STEMI, NSTEMI, and unstable angina. The difference between an NSTEMI and unstable angina is that in NSTEMI there is elevation of the cardiac enzymes, but whereas in unstable angina, there is typical ST changes of ischemic changes in the ECG without any increase in cardiac enzymes. So coming to the definitions of myocardial infarction, this is actually the fourth consensus definition, which was given in 2018. Actually, for diagnosing a myocardial injury, it was said that there should be an elevated cardiac troponin levels with at least one value above the 99th percentile of the upper reference limit. And along with that, there should be acute rise or fall in this troponin levels. So for diagnosing acute myocardial infarction, we need to have an acute myocardial injury along with the clinical evidence of myocardial ischemia, and along with that, rise and fall in cardiac troponin level with at least one value above the 99th percentile of the upper limit. Along with that, the patient should have at least one of these things: symptoms of myocardial ischemia, new ischemic changes on ECG, development of pathological Q waves, or any imaging evidence of loss of new regional wall motion abnormality, which is which pattern is consistent with ischemic etiology. And apart from this, there is another entity like the for percutaneous coronary intervention related myocardial infarction. We have to.
So this we can leave. This is more for the cardiologist cath lab. Just go to the previous slide.
Okay. Okay.
So it is very important to realize here that troponin has to be positive. There should be a rise or a fall in two values taken at least 6 hours apart, and one of the remaining criteria. And you, as you may note, ECG can be normal because that is not a definitive criteria.
Definitive.
So troponin is very important for the diagnosis of acute myocardial infarctions. Non-STEMI, that is most important. Please carry
on. So to summarize everything into a single slide, this universal definition divides myocardial infarction into 5 types. Type 1 is a spontaneous myocardial infarction, which is primarily caused due to a plaque rupture leading to coronary thrombosis. Type 2 myocardial infarction is classified in patients who have a supply-demand mismatch. There is a mismatch between the myocardial oxygen supply and the demand of the myocardium, rather than any existing coronary artery disease. Type 3 is a suspected MI-related death, where the patient dies before we can get the results or can take the sample of the cardiac biomarker. And as I was telling previously, type 4 is PCI related, type 4A. Type 4B is for stent thrombosis, and type 5 is CABG related myocardial infarction.
So this is just one sec, just go back. So yes, type 1 is the classic MI, and type 2 is a supply-demand mismatch, such as seen in situations of severe hypoxemia, hypotension, due to thrombotic conditions, which is not classically atherosclerosis, or maybe vasculitis or dissection in the coronary arteries. And this type is also known as MINOCA, MINOCA. Infarction in non-obstructive coronary arteries. Used for type 2. Carry on.
So this, as sir has already said, in type 2, there may be oxygen demand supply mismatch due to various reasons like vasospasm or a coronary dissection or a simple oxygen supply demand mismatch. So coming back to our case, so this patient was being managed at the ER. So we had put an IV access and set the initial set of investigations. As this patient was conscious and he was his airway breathing circulation were normal at that point of time. So we secured an IV access, sent the relevant investigations like high sensitivity troponin I, his coagulation profile, his CBC, urea creatinine, and electrolytes. Along with that, patient received a loading dose of aspirin, 325 milligram at that point, which was chewed. And since this patient was having a STEMI and he was planned for a percutaneous coronary intervention, we loaded the patient with a ticagrelor 180 milligrams. And along with that, we gave him an atorvastatin of 80 milligrams. And for pain relief, patient was given 50 mics of fentanyl. And since this patient was also having a heart failure, he was given a furosemide 20 milligram injection and an unfractionated heparin bolus of 2,500 units was given, keeping in mind that he was being prepared for an primary coronary intervention.
So, Dr. Devkamal, what else can you give for pain relief apart from fentanyl?
For pain relief purposes, nitrates can be used like a IV GTN or sublingual isosorbide dinitrate can be given. But for this patient, we avoided it because his BP was on a lower side, and there are certain contraindications of using this kind of.
Yes, nitrates lower the blood pressure, so you cannot use in right ventricular MI or in hypotension.
Hypotension.
You can use for pain relief.
Pardon, sir. Pardon, sir. I couldn't
Any
get it.
other drug you can use for pain relief?
So for pain relief, we can use opioids
Fentanyl?
like
Yes,
morphine.
morphine. Yes, that's
Morphine we can use, but there are certain studies have shown that giving morphine right at the onset means there it may not be means there are certain adverse events, means when the head-to-head trials have been done when with morphine and without morphine, the patient who received morphine, approximately 9% of them had an adverse outcome. Means there are certain problems with morphine like sedation and hypotension itself, and uh, uh, so right at this point of time, giving morphine to all patients of AMI is not at all recommended.
so. See, morphine. The problem with morphine is morphine causes venodilatation, and
Yes, sir.
patient is in hypotension, then you have to be careful with morphine. And morphine should be started in low doses. You should not give a higher dose. But
Yes, sir.
in the textbooks of cardiology, like Grunwald, morphine continues to be the drug of choice. But you have very rightly said there is controversy with morphine. But at the same time, one can remember that morphine, low doses, may be given.
May be given.
There is some controversy with morphine. But just to point out that morphine also can be used, but definitely hypotension can be caused with morphine, and it can cause bradycardia also at times. So,
Yes, yes, sir.
and the other thing is the heparin dose. I would have liked to give him a higher dose here, because this is obviously a myocardial infarction, and 5,000 units bolus should be given rather than 2,000 units.
So, sir, actually, our patient was of body weight 50 kgs. So the recommended dose of IV bolus is around 50 to 70 units of heparin right at the onset. So we kept it on a lower side. So that's why we
Okay, body weight was less. Okay, fair enough. Carry on.
Okay. This patient was being prepared for and urgent PCI techniques. And since our institute is a PCI enabled center, we didn't opt for a thrombolytic therapy for this patient. But if this patient presented at a center which is not PCI enabled, then and this patient presented to us within 12 hours, so thrombolytic agent can be an option for a center where PCI facilities are not available. Means if the patient can be referred to a PCI center within 120 minutes, means door to balloon time is within 120 minutes. At that point of time, we will refer the patient or transfer the patient to a PCI enabled center. But if it is not, then we may thrombolize the patient. The options are tenecteplase, alteplase, reteplase, and streptokinase.
So which is the best one out of this? Which gives the best?
Out of this, the tenecteplase is the best one because it is much more thrombin means specific plasminogen activator, and it is given as a bolus dose. And
so that is also an advantage. It is just a single bolus dose, immediate single bolus dose.
Single bolus dose, exactly.
And the dose is weight dependent. In a 70 to 80 kg man, it is 40 milligram, and the dose varies with the weight.
With the body weight.
Advantage of streptokinase.
Pardon, sir. Pardon, sir.
What is the advantage of streptokinase?
Advantage, say, streptokinase, sir, it is very cheap.
Very good. So it is very cheap in our setting. So affordability becomes an issue sometimes. So streptokinase is a very cheap drug compared to the other.
Compared to the other.
So just go back to the previous slide, please. Yeah. So one thing is the mechanism of action of nitrates. So, wherever the blood pressure allows you, please give nitrates also, either as an infusion or sublingual sorbitrate. Nitrate decreases preload, decreases afterload. So thereby it decreases the work of the heart and oxygen requirement. And at the same time, it opens up collateral circulation. So nitrates is a very important drug and they should not be ignored. The only contraindication being if there is hypotension or if there is RVMI, which is with borderline blood pressure. So there you have to avoid nitrates. But otherwise, nitrates are a very good drug in the setting of acute myocardial infarction. Carry on.
So when this patient was being evaluated at the ED, After approximately 20 minutes of his presentation, this patient suddenly becomes unresponsive and pulseless. So CPR was immediately started as per the ACLS protocol, and this patient
was he on the monitor at this time?
Yes, he was on the monitor.
So the rhythm was what? Was he bradycardic or tachycardic?
No, it was means the monitor was showing 0 at that point of time.
Okay.
When flatline protocol was applied, we increased the gain. At that time, this kind of ventricular fibrillation waves were noted. So this patient was immediately given a 200 joule biphasic shock, and he reverted to sinus rhythm. But still he was pulseless, so he was intubated. CPR was continued, and ROSC was achieved after 3 cycles of CPR. And after ROSC, patient was assessed neurologically. He was awake, he was moving all 4 his limb, but he was not obeying commands at that point of time. His BP was 76/50 with noradrenaline of 0.1 mics per kg per minute. His pulse was 150 per minute. He was saturating around 90% with FiO2 of 100% and PEEP of 6. And during this...
So were you there at this time, Dr. Devkamal, at this time of CPR?
Sir, this was managed primarily by our EP team, sir.
Okay.
So
if this situation is occurring here, you said that the monitor showed a flat line.
Yes, sir.
And CPR was started, cardiac massage.
Yes, sir.
And then it showed ventricular fibrillation.
Actually, we did for the as per the ACLS protocol, we have, whenever the monitor shows a flat line, we have to go for increasing the gain and see the actual rhythm. Sometimes in the cardiac monitor, the gain is kept lower side. At that point of time, ventricular fibrillation mimics like a assistole. So that is the point which I wanted to highlight.
It was actually in ventricular fibrillation, but it was showing a misleading flat line.
Yes, sir.
So now, one thing you can tell for the students how to do the cardiac massage here and how to give the shock when you see the situation.
For cardiac massage CPR.
Yeah, now the patient is in ventricular fibrillation, right?
Yes, sir.
Ventricular fibrillation. So what will you do?
Well, we will first of all, when it is a shockable rhythm, we will deliver a shock of 200 joules.
Before delivering the shock, you have to prepare the defibrillator, right?
Yes. During that time, we will initiate the CPR.
Yes. The cardiac massage has to be started.
Yes, definitely, sir. And when the defibrillator machine is ready, we have to deliver the shock as early as possible. And after that, we have to continue the CPR for another 2 minutes. And then
absolutely, very good. So that is the most important point. After delivering the shock, one should not see the rhythm. One has to continue cardiac massage for 2 minutes.
2 minutes, and then assess whether the pulse has come back.
The heart is getting circulation. Otherwise, the circulation will go away. That is excellent. Carry on. That's the point I tried to make.
The echocardiography was done at the ER at that point of time. The ejection fraction was 30%. There was anterior and anteroseptal area hypokinesia, and it was also associated with grade 2 diastolic dysfunction. So this was the first time echocardiography was done for this patient, because actually this patient has collapsed within 20 minutes of presentation to our ER. So what do we do next? First of all, reperfusion is already on our mind, but at this point of time, the patient is having a BP of 76/50. So his BP is very low. So for medical management purpose, he is already on noradrenaline. So we have to maybe increase the dose of the ionotropes or the vasopressors, and we may use ionodilators to not at this point of time, because his BP is very low at now. So noradrenaline, adrenaline or dobutamine may be used if his BP is on the systolic BP is more than 90. If we are able to achieve that with the vasopressor, then we can think.
So Dr. Panja, sir, Dr. Panja, please come in, sir.
Yeah.
So here, I would just like your opinion. The pressure is 76, but he's on a very small dose of NORAD, and dobutamine is the real drug used actually for cardiogenic shock. The patient is in cardiogenic shock. He has acute coronary syndrome, ST elevation, MI. Do you think it would have been feasible to increase the NORAD and add dobutamine also here?
No, ideally, this patient is having, we should here, most important thing is dobutamine or sometimes whatever phosphodiesterase inhibitor like milidone. These are basically comes in the as I know dilator. So initially our vasopressor should be started, particularly either adrenaline, noradrenaline. So this will be the best choice. So that's why the right now guideline says that noradrenaline will be the best at this point, and we want to bring up the actually the perfusion pressure by increasing the mean pressure. So not epinephrine should be used, and if the systolic blood pressure is usually less than 80, particularly some people prefer that less than 90, so don't go for the immediately dobutamine or other drugs like milrinone. Okay, so because these are inodilators, there is a possibility that this may also precipitate the EA. And secondly, one is tachycardia. So with dobutamine, patient might have more tachycardia. That is another problem. So that's why initially we can start with the noradrenaline. And then if the condition suits or the heart rate is not very high or the pulse rate is less, or within 100, 110, then you can consider, and also the systolic blood pressure is usually 80 to 90 or more than that, then you can consider putting the patient on dobutamine.
Okay, sir. Carry on, Dr. Dev.
So the other options which we had for this kind of patient is intra-aortic balloon pump or other mechanical circulatory support devices like Impella, tandem heart, Centrimag, or HeartMate. And VA ECMO is also an option for this kind of patients. So first of all, what we decided is that we should immediately shift this patient to the cath lab, do the reperfusion, and see how the patient responds to it. So, uh, uh, so coming back to the definition of cardiogenic shock, basically it is a low cardiac output state resulting in life-threatening end organ hypoperfusion and hypoxia. And as in different trials, the objective clinical criteria which we follow is usually the systolic BP less than 90 millimeters of mercury for more than 30 minutes, along with other end organ hypoperfusion evidence like decreased urine output, or considering the as Dr. Bansal had previously said, the hemodynamic criteria of cardiac index less than 2.2 and pulmonary wedge pressure more than 15 millimeters of mercury. So this patient was shifted to the cath lab, and the angiography features revealed that there was a
No, just go to the IBP.
Yes, sir. Yes, sir.
Okay, so this we can come to later. I think you might have put the IBP. Go on.
Yes, sir. Yes, sir. So basically, revascularization was done to the culprit vessel. Means though the other arteries were also stenosed, the LCX had a 70% lesion and RC has a 60% lesion. But the culprit artery for this patient was LAD because it was showing a 90% blockage along with the thrombus in situ. So according to the guidelines, it is always recommended when a patient is in cardiogenic shock to put to perform the primary coronary intervention to the culprit artery only, not to the non-infarct artery at that point of time, because there is higher risk of death or renal failure for this kind of patients. So, so this patient at that point of time, the cath lab itself, after they had put in a stent to the LAD, the hemodynamics didn't improve that much. Okay, so this patient was put on an IABP at that point of time because IABP still remains the most easily available, most frequently used mechanical cardiac support device at this point of time. And though the studies which have been conducted, like the IABP Shock 2 trial, it doesn't recommend, or it shows that it does IABP did not significantly reduce 30-day mortality in patients with cardiogenic shock. But considering our experience with IABP and the ease of use of this device, we thought of inserting it for this patient because the blood pressure was still remaining low for this patient in the
What were the CAG findings, Dr. Devkaur?
The CAG findings were there was a 90% lesion with thrombus in situ in the LAD. The LMCA was clear, but the LCX had a 70% lesion and the RCA had a 60% lesion.
So he has a triple vessel disease, huh?
Yes, he has a triple vessel
So
disease.
when do you say that the patient has coronary artery disease in general, Dr. Devkaur?
In general,
on basis of CAG.
On the basis of CAG, if the lesion is more than 50% in a single artery with ischemic means
yes. So if
there
the
symptoms of
lesion
ischemia.
If the stenotic lesion is more than 50% in one of the major epicardial vessels, it is called coronary artery disease. Huh? So
yes,
second question is, can you have a normal CAG after MI?
Yes, patient may have a normal, as you had previously said, like Minoca is a term used for this kind of AMI. Means if there is any kind of vasospasm, like Pringe metal angina, or there is some kind of a myocardial oxygen demand supply mismatch due to any reason, due to hypotension, hypoxia, that kind of patient may present with a myocardial infarction, but will have normal coronary angiopathy.
Yes, so that is one reason. One is vasospasm, which can relieve, or if you are having hypotension, severe anemia. Second is, even in classic coronary artery disease, sometimes the thrombus self-lyses. The thrombus forms and it self-lyses. So you can angiogram. Sometimes it is not. So one gets surprised sometimes, but it happens sometimes.
It happens, yes.
Going back to the IABP, please go back to the IABP.
Yes, sir.
So Dr. Panja sir, please come in. Can you please explain the principle of IABP to our audience?
I think Dr. Oyan also joined. He
Yeah.
can also take part if Dr. Oyan is there.
Yes, I'm here.
Okay.
So please introduce him, Dr. Panja sir, if you will introduce him.
And Dr. Oyan Kaur is our senior cardiologist working at our RN Tagore Narayana Health RN Tagore Hospital in Calcutta. And not only that, he is also a coordinator for our heart transplant program. And he actually was involved in this particular case. And he is an interventional cardiologist, as well as he has very keen interest on cardiac transplant, as well as different type of mechanical circulatory devices. So I think he will be the right person to give the next proceedings.
Dr. Aryan sir, can we have your video? Can we have your video, sir?
So Dr. Aryan,
I'm sorry, sir, but I'm traveling.
Yeah. That's okay. So Dr. Aryan sir, we are on IABP. So can you explain the principles of IABP? If you can talk on IABP for our young audience, use the principles, etc.
Yeah. So as you see, IBP basically involves a balloon which is inserted retrogradely from the femoral root, and it basically, as we call it, it's called an intra-aortic balloon pump. It is used for diastolic augmentation as well as for systolic offloading. So it does two basic functions, which is why it's very important that your IBP balloon is adequately sized before you take it up. So depending on your height, you get different types of balloons. Ideally, in general, most adults, they generally require a 40 cc balloon. We have bigger balloons and smaller balloons, but smaller balloons are mostly for pediatrics, and larger balloons, of course, for patients who are, let's say, 6 foot plus. So what this balloon basically does is, it typically, as you can see from the graph out here, if you notice down, look at the aortic trace, you would see that there is a general peak in the middle of diastole, which tells you is what is known as the diastolic augmentation. And that happens because the balloon is made in such a way that it is made to inflate during maximum, so that it blocks the blood flow forward and improves coronary perfusion. At the same time, what it does is during systole, it deflates, thereby causing a vacuum in the descending aorta and pulls more blood in front, and thereby actually mechanically offloading the heart. So which is why you'll see that the next diastolic pressure is generally much lower than the previous one. So which the systolic pressure, sorry. So which is why it's called systolic offloading and diastolic augmentation. So that is exactly the principle of an IBP balloon, and as Devkamal has already suggested, most of the trials seem to have a negative vibe about using an IBP balloon. I think, but that is not quite true given our experience. If you're able to rush in an IBP early on in cardiogenic shock, the general results are much better rather than trying with inotropes.
Yes. So thank you, sir. So I'll just summarize that. So the IBP inflates during diastole and the time and deflates during systole. So it increases the diastolic coronary perfusion of the LV. It decreases the amount of work that the heart is doing, the left ventricle, and decreases the oxygen requirement. It increases the MAP to a certain extent and thereby improves the overall performance of the heart. And the timing of the inflation and deflation can be done either with the aortic trace or with the ECG. So carry on, Dr. Devkamal.
We got this patient back into our ICU. Okay. So this patient was on analogous sedation with midazolam and fentanyl. His heart rate was 120 per minute. His BP was 96 by 54 on noradrenaline of 0.1 mics per kg per minute. He also had a pulmonary atrial catheter inserted in the cath lab itself. The PCWP was showing a 26 millimeter of mercury. His cardiac index was 2.3. He was put on IV furosemide infusion 3 milligram per hour, and IBP was inserted as I had said earlier. It was giving a 1:2 augmentation. This patient was saturating of 90%, around 90% with FiO2 of 0.8 and P of 8. And his urine output was on the lower side. It was just 0.4 ml per kg per hour. Okay.
Okay. So Dr. Aryan sir, you'd like to comment on the hemodynamic indices here, the blood pressure, the wedge, and the cardiac index?
Yeah, so I think I'll sum it up for you. So what this basically shows is that you have very increased filling pressures both for the right as well as the left heart. We definitely tell you that it's a failing heart and it's not able to produce adequate cardiac output. So typically we would like to combine an IBP with some form of a vasopressor. In that case, it generally is noradrenaline or vasopressin, so that it takes care of the peripheral vasodilatation that generally happens in IBP patients. I think we were talking about why this patient has a low diastolic BP towards the initial part of the presentation. I think most of our heart failure patients, of course, this was an acute setting. They tend to get a lot of vasodilatory drugs, specifically hydralazine, nitrates, as well as sometimes the new molecule known as ARNI, which typically puts these patients into a very vasodilated state, and that makes it very difficult when they come in with worsening heart failure. So I think here we have very high filling pressures as evidenced by a wedge of 26, as well as I think, did I find a mention of a CVP out here? I guess the CVP is not here, but I'm guessing the CVP will also be as high.
Yes, it was high, sir.
So Dr. Aryan, the diastolic is still 54, which is unusual for a patient of cardiogenic shock here now.
I'm sorry, sir.
The diastolic is still 54. That would be unusual for someone who's in cardiogenic shock. Of course, we have systemic inflammatory response syndrome now being described in cardiogenic shock, which can lead to vasodilatation.
So we need a certain optimal diastolic BP for renal perfusion. So we as cardiac, we not even
we can't hear you, Dr. Aryan.
Generally
Dr. Aryan, we can't hear you. We can't hear you.
I'm sorry, I'm traveling, sir, but it's
I think you'll have to switch off, sir, because we can't hear you. So okay, so
I'm already
continue with Dr. Aryan, because this way there's too much interruption. So the wedge is high and the cardiac index is 2.3, and he's still on the same dose. So there's no real. I think this is the first slide after coming out of the cath lab.
Yes, sir. Yes, sir. This is the first.
So, okay, carry on then.
So we got his initial set of labs with us. His hemoglobin was normal 11. His total count was on a higher side, as we expect in a patient of AMI. It was 15,000. His urea was 69, and creatinine was 1.6, which was a bit on the higher side. And his sodium electrolytes were normal. INR platelets were normal. His liver enzymes were starting to go up a little bit, as evidenced as the patient was already in shock. His albumin level was normal, and his high sensitivity troponin level was also very high. It was 40,000, which was
So,
sent
Dr.
initially at the
Devkamal, what is the difference between HS tropi and tropi?
So high sensitivity tropi is basically actually in high sensitivity tropi, the detection of the in the lab parameters, a small level of nanograms of troponin can be detected, whereas in normal troponin I, which we send or we do in a kit based test, they are actually very much not very sensitive. Means this is the most sensitive cardiac biomarker available till now. So
Yes.
this high sensitive.
So high sensitivity is actually more for non-STEMI ACS, where you have microinfarction, and it gives the result in 3 hours. So there it is much more helpful. While for STEMI, actually tropi is good enough.
Tropi is good enough.
Other thing is potassium. Potassium is 3.8. So what level would you like to keep potassium at? Is there any recommendation?
So this patient already had an arrhythmia. Okay, so my actually the potassium level which we should aim for is between 4.5. Means 4.5 to 4 will be the range between which we should
it should
keep
be
our potassium.
above 4. Potassium should be kept above 4. And we would also like to look at magnesium. Magnesium is very important also, because in terms of magnesium also should be kept normal. That is something we should always do in a patient who's so sick with myocardial infarction.
Yes, sir, definitely.
And you have mentioned SGPT and SGOT going high because of ischemia. Is in hypotension, relative hypotension. Is there any other SGOT is high?
Pardon, sir? I couldn't get you.
See, SGPT and SGOT is high. So one reason is he's in relative hypotension.
Hypotension. Yes, sir. Yes, sir.
Is there any other reason why SGOT can be elevated here?
So the SGPT can be
SGOT.
SGOT. Specifically, this patient didn't give a history of any alcohol abuse previously, so we don't know.
So actually, Devkamal, SGPT is very specific for liver, but SGOT come from
it is a cardiac.
Yes.
Cardiac.
So before we had troponin and all, SGOT was one of the cardiac enzymes which was done to diagnose.
To diagnose, exactly.
Okay. So that was 10, 15 years ago. So SGOT, if it is disproportionately increased to SGPT, think of heart and think of muscle. It comes from muscle and heart also.
Muscle and heart. Okay. Yes.
So now can you interpret the ABG for our audience? What is the ABG diagnosis?
So the ABG is showing hypoxia along with high anion gap metabolic acidosis. So because the lactates are 4, the pH is on the lower side, bicarbonate is low.
So is this compensated acidosis or non-compensated metabolic?
It is not compensated by the CO2 because the pH is in the 3.2 range.
What is the Winter's formula?
Winter's formula, it is used to predict the amount.
Can you apply it here? What is the Winter's formula?
Winter's formula is 1.5 into bicarbonate plus 8 plus minus 2. 1.5
so how much is the PCO2, expected PCO2?
Expected PCO2 is over here 1.5 into 18. That means 27 plus 8. 27 plus 8, 34 plus minus 2. So it is 36. Means
so it is compensated.
Yes, it is compensated. Right.
So pH sometimes does not return to normal exactly, huh?
Yes. The body tries, but it.
Yeah. So the pH may or may not return to normal. The compensation in terms of the formula should be complete. That is important. So this is compensated metabolic.
Compensated metabolic acidosis.
Carry on.
So this was the X-ray which we got. It was showing evidence of lung congestion. Bilateral bat wing shaped shadow was there. Pulmonary catheter is in situ. Endotracheal tube is in place.
So can you show the tip of the catheter with the marker?
This is the tip of the PAC
Okay.
catheter, and over here we can see the tip of the IABP balloon over here.
Okay. Carry on.
So coming to our case on day 2, this patient was still on ventilator. His hypoxia was worsening. His heart rate was 100 per minute. His BP was slowly coming up with noradrenaline and adrenaline support. His capillary wedge pressure was also creeping up slowly. It came up to 27. His cardiac index was also dropping. It was 2.2. He was still on IABP 1:2. It will be 1:2 augmentation. It won't be 1:1. He was saturating around 88% with FiO2 of 1 and PEEP of 10. His urine output also dropped to 0.1 ml per kg per hour in spite of him being on furosemide infusion 5 milligram per hour. So this patient was worsening on all parameters.
So the cardiac index is the same. The wedge pressure is also the same. The blood pressure has fallen, right? Because the requirement has increased.
Yes. Blood pressure has fallen.
You know, the map has gone up with your increased dose. You have increased the dose, so the map has gone up.
Yes. But the requirement has increased considerably because previously he was on noradrenaline support of 0.1 mics, and right now adrenaline has also been put on.
But the pressure has gone up, so you really can't make out much. The cardiac index is the same.
Yes, cardiac
has come down. It was 120. I think it is down to 100 now. So next slide, please.
Yes. Since admission, this patient was the total intake was around 3 liters or 2.7 liters, but he had only poured out an urine of around 715 ml. So his urine output was on the lower side. His hypoxia was worsening. So it was decided to initiate him on renal replacement therapy. We selected SLED for this patient because in our institute SLED is available at this point of time. CRRT is not available. So we decided to give 2 sessions of SLED to this patient. In the first 24 hours, we did an UF of 1 liter in the first session of 8 hours. And the next session, we gave an ultrafiltrate of 1.5 liter to this patient. And we tried to achieve at least a negative balance for this patient at that point of time to improve his hypoxia.
Okay, carry on.
So on day 5, 6, hemodynamics worsened further. His heart rate went up to 140. His BP came down to 80/50 with increased amount of NORAD and adrenaline. His pulmonary capillary wedge pressure was also on the higher side. It was 30 millimeter of mercury at that point of time. The catheter was displaced to the zone 3, so it may have led to overestimation of the wedge pressure. His cardiac index came down considerably. It was 1.7. He was still on IBP augmentation of 1:2. His saturation was also not keeping up. He was still requiring very high oxygen. His urine output was also still low, and his lactate was also found to be high. On that day,
So just go back. So now what is happening here is very importantly, the blood pressure has fallen and the cardiac index has fallen, right? So
yes.
Cardiac index is actually cardiac output by body surface area. So the cardiac output has fallen, in other words. So Dr. Devkamal, what is the relationship between blood pressure and cardiac index? or cardiac output?
Cardiac outputs, the cardiac output is equal to stroke volume into heart rate. The stroke
Right.
volume is dependent on different factors like preload, contraction, and afterload. So this blood pressure, the diastolic BP gives
So a
us the
simple
systemic.
question: what is the relationship between MAP or the blood pressure and cardiac index or cardiac output? Index or cardiac output?
If the mean atrial pressure is low, so the cardiac output will be low. That is the normal thing which we
see. The relationship is that the blood pressure is equal to cardiac output into systemic vascular resistance.
Yes.
The MAP precisely.
Yes, yes,
MAP is equal to the cardiac output into systemic vascular resistance. So because your cardiac output is falling, your blood pressure is falling here.
Resistance.
Okay. And that is the most important thing to realize. And why is your cardiac output falling? Like you said, cardiac output is equal to stroke volume into heart rate. So here the heart rate has jumped up to 140. So that will decrease the diastolic time available to fill the heart. One, your stroke volume will go down. Second, has something else happened here? Has the cardiac function deteriorated, which may be because of reinfarction, because of mitral regurgitation, because of development of ventricular septal defect, all these complications, or development of a pericardial effusion, resulting in some degree of death, complications of myocardial infarction. Output is falling clearly.
Yes.
That is actually to analyze it. So repeat echo is very important here. Carry on.
Yes, sir. Okay. We did an repeat echo. It showed that the ejection fraction had come down to 90%. The anterior wall, which was hypokinetic previously, had become akinetic. There was new onset hypokinesia in the anteroseptal and the lateral wall, and there was grade 3 diastolic dysfunction. So
what is the interpretation here if you compare to the previous echo where there was only anterior and mainly anteroseptal wall motion abnormality?
Involvement.
The new
right
regional
now
wall
the
motion.
other. Yes, sir. So the other lesions means other arteries which was having lesions on cardiac angiography, maybe due to this shock stage and due to hypoperfusion of those parts of the myocardium, it was not functioning well appropriately. So his ejection fraction was.
You see, what is happening probably is one, the grade 3 diastolic dysfunction is also occurring. Your pressures in the left ventricular are going up. The coronary perfusion depends on your diastolic pressures.
Yes.
And the difference between the diastolic blood pressure and the LVEDP, because the left ventricle gets coronary perfused and diastole. So because you are having hypotension and because your LVEDP is going up, the coronary perfusion is very poor. One. Second is he could have had a reinfarction in one of the other territories because there are new regional wall motion abnormality. Exactly. So the heart function is clearly deteriorating. And if you have a recurrent MI, then troponin does not help normally. You have to do CPK-MB. That is one of the advantages of CPK-MB because it has a short half-life. Within 72 hours, it comes. So if there's a rise again, you can make out there's a reinfarction.
Reinfarction, exactly.
So as you can see, the creatinine is worsening, the urea is worsening, so it's gone into ATN, and your HGOT-PT has gone up tremendously. So ischemic hepatitis is worsening. So all these things are happening here. Patient is clearly deteriorating, primarily because there is new onset cardiac dysfunction occurring. Because initially, he was not so bad. 30% of EF with only V1 to V4 involvement is not that bad for a patient. So first, to whatever process is occurring, as we have discussed. So Dr. Panja sir, comments.
Hello.
Yes, sir.
Oh, am I audible? Yeah. I think you are absolutely right, because this patient was, if you compare with the previous one, as Dr. Devkamal mentioned, that there must be some reason that the secondarily has happened during the course of their hospital, this patient's hospitalization. So maybe because of the reinfection of the already diseased artery, or sometimes it may be that this patient also had one episode of the ventricular tachycardia, and that time because of the hypoperfusion, as already we have mentioned in the initial part, that the type 2, where there is actually supply demand mismatch, so that can give rise to an acute coronary syndrome that will mimic type 2. So that may happen in this patient. Not only there are also stunning or phenomena is the stunning of the some of the myocardium may happen during the course of their patient's hospitalization, the myocardium. So that may be the reason for these changes. Okay. So sometimes it may revert, sometimes it may not revert. But I think in this case, this patient, because patient already on a optimal supportive system, but still now the patient is not showing much improvement. So we should do something for this particular patient. So that was the initial thought that our team members actually managed that case.
So only one thing, Dr. Panja sir, initially the blood pressure was 9500. At that time also, dobutamine was not really used by your team. I would have preferred to use dobutamine with noradrenaline, because dobutamine definitely improves the ejection fraction, the contractility, and all this while he's in pulmonary edema. And once you improve the cardiac output, the lungs get decongested, the filling pressure decreases, and the overall perfusion increases. Because the idea is to increase the perfusion by virtue of cardiac output rather than by vasoconstricting it with noradrenaline, because already these patients are in extreme vasoconstriction normally. The sympathetic tone is very high. So, and worldwide it has been seen the first, I know dobutamine and then
If I
noradrenaline.
if I could interrupt you, sir.
Yes.
I'm sorry, but dobutamine is really not going to help this patient. I don't think so. It is not worth trying. Rather, dobutamine tends to be very arrhythmogenic in these kind of subsets. It is always better to go for more advanced form of mechanical circulatory support. There's no point slugging this heart with more vasopressors.
No, I agree, sir. But generally, dobutamine and noradrenaline are the two drugs which are most widely used before you use mechanical. I agree
So
with
with
you
a
that.
heart rate of 140, dobutamine, I think, is not the best choice. I mean, here you
Okay.
have to do something to bring down the heart rate to often heart mechanically. Here,
Right, right,
dobutamine is going to make it far worse.
right. Okay, carry on, Dr. Devkamu.
So this was the X-ray. It is completely evident that this patient is his LV is failing. His chest X-ray has worsened, and it is full of infiltrates, and we are basically dealing with a failing heart at this point of time. So this is the management pathway we actually come across for the cardiogenic shock patients. If the patient with reperfusion improves, they go into the recovery stage. If not, then patient has to be put on mechanical cardiac supports. There are numerous options. The patient is already on one of them, IAPP, and along with the vasopressor support, the other options which we have in our hand is a peripheral VAD, a ECMO, or an implantable VAD, because this patient may ultimately land up with either a destination VAD or a transplant at this point of time, which it looks like. So coming back to our patient, this patient didn't improve with any kind of therapy, means the conventional medical therapy and the IBP support. So cardiac surgery opinion was taken at that point of time. So the question which we had on our mind was whether to go for a VA ECMO or a LVAD for this patient. It was primarily decided to go for a LVAD, considering the cost benefit, the experience with the device, and everything. CentriMag was chosen, and after CentriMag insertion, his hemodynamics improved to some extent. The patient became comfortable, his ABG improved, his lactate came down, his urine output was also slowly coming up. So basically, when we come to mechanical circulatory support devices, These are the things available: IABP, Impella, then a tandem heart, or VA ECMO. The device which we chose was CentriMag. This CentriMag is basically biventricular support. Over here, the out for the right ventricle, the outflow from RA is taken out, going into the centrifugal pump, and then it is pumped into the pulmonary artery, and another pump is added to the LV apex attached, and it pumps the blood back into the ascending aorta. So this is the configuration which we use for CentriMag, and we decided to insert it to our patient. And on day 8 to 13, the patient still required sessions of SLADE due to his low urine output and intermittent pulmonary edema. This patient remained very much sensitive to his fluid balance during this period. His oxygen requirements often increased just after 3 to 4 hours of completion of the SLADE, and but it was controlled during the sessions of SLADE. So this patient was having a topsy-turvy course of hospital stay at that point of time. So this patient was in our ICU for approximately 14 to 15 days. And as many of our patients, after this amount of stay in our ICU, develops a fever spike, his hypotension occurred, his vasopressor requirement again started coming up, his oxygen requirement was also jumping up. So we sent a blood CS, ETCS, and a gram stain culture and a urine culture at that point of time. Since the TLC count has also jumped up to 31,000 at that point of time. So initially the patient was put on a third generation cephalosporin at that point of time. Well, the patient was on third generation cephalosporin. So the antibiotics were escalated to meropenem and teicoplanin at that point of time, and we waited for the culture reports to come. So the ET culture grew, ESBL producing Enterobacter C, which was sensitive to meropenem at that. So meropenem was continued. It was given 1 gram IV twice daily, considering his renal creatinine clearance values, and the teicoplanin was discontinued. His fever gradually settled down, his hemodynamics improved, his vasopressor requirement gradually came down, his oxygen requirement also slowly came down. And on day 21, 22, this patient could be weaned off his ventilation and he was extubated. This patient was basically put on intensive physiotherapy. He was put on nutritional therapy because he had lost a significant amount of weight during this
So what
period of
nutrition
time.
were you giving him? Were you giving him TPN or were you feeding enterally?
No, we were feeding him enterally, sir. The patient had rice tube during this period of time. We were giving him a high protein diet with enough calorie
So,
and
Dr. Panja sir, your comments on feeding such a patient who's on shock, whether you should go for TPN or whether you should go for enteral?
In the initial part, this patient was during the initial first week, this patient received very high protein diet through the parenteral route during the initial days. And later on, after that, about 10 to 11 days, gradually, once the vasopressor requirement was relatively reduced, then the patient received actually both parenteral and enteral. And our protein was basically, we had given approximately 3 grams per day of protein, considering two things, because this patient was in a very high catabolic load and patient was already on hemodialysis, particularly the SLATE patient already received. And from almost 17 or 18 days, it was only enteral route that gradually we switched over to the ear. By that time, the vasopressor requirement was gradually coming down. And patient was later part during this time also patient was extubated and basically weaned up from the ventilator. So this was the patient received.
So that is a very important message from Dr. Panja, that when the patient is in shock, uncompensated shock or escalating doses, you cannot give nutritional therapy in terms of at least enteral. Some parenteral can be given once the patient stabilizes, and once the shock starts resolving, is on lowering doses of vasopressors, then enteral can be started. And 1.3 gram per kg is the standard dose of protein. And of course, if muscle mass is being lost, you can increase it. And some increase is done for proteins on patients on CRT also. So it's very important. Feeding has to be maintained, especially with prolonged stays in the ICU. Otherwise, they come into a lot of problems, weaning problems, immunodeficiencies leading to secondary infections, etc., etc. So those things are very important.
So basically, we were waiting at this point of time. We were waiting for donor heart, because this patient was maintaining on Centrimag. So he was being rehabilitated properly so that his muscle mass increased. The nutritional therapy was given. He was put on intensive physiotherapy. And finally, on day 28, we could mobilize this patient along with his Centrimag. And this is the video which we could capture. So he, at that point of time, the patient was looking very bright. He was moving around in the wards of the ICU along with this mechanical support device in situ. And finally, on day 42, we received a call from the Roto, and a donor heart was available for transplant. So this heart transplant was done on day 42, and post that the patient could be weaned off the ventilator on the second POD. And this patient on day, this is the patient, he's doing spirometry with all the lines out and everything. The patient was recovering very well, and it was very fortunate that we could successfully manage this patient, and we could finally discharge this patient to home on day 60. So this was all about this acute coronary syndrome case which presented to our hospital. We went into irreversible cardiac failure, and with mechanical support device and finally heart transplantation, this patient could go home.
So please switch off the power steering. So thank you, Dr. Devkamal. Wonderful, excellent presentation. And many congratulations to Panja sir team and Dr. Aryankar and everybody for managing such a complicated case and coming through this transplant. Wonderful. Just a few points I would like to make. You know, when we have such patients and they do not do well.
Hello, sir. I couldn't get you what you were saying.
Can you hear me? Hello? Are you able to hear me?
Dr. Bansal, you are not audible properly.
Am I audible now?
Yes,
hello?
Yeah, right now you are audible.
Okay, so I would like to congratulate Dr. Panja sir, Dr. Kar sir, and all the other people who are involved in this. Wonderful to see this, heart transplants being done in our country so successfully, such complicated cardiac cases requiring intensive care being managed wonderfully well. And Dr. Devkal, lovely presentation. Many congratulations to you too. We just make a couple of points. We have these cardiac patients with poor LV function, whether due to MI or sudden poisoning, self-force poisoning, viral myocarditis. So we do the vascularization in the patients of coronary cases, or we put them on support, inotropic support, vasopressor support in other cases like myocarditis or self-force poisoning or other toxic poisonings to the heart. So once these patients are on an escalating dose of your vasopressors or your dobutamine or whatever drugs you are using, or you go on to double drugs, that is two drugs, if they're not improving, then we should not delay the use of mechanical circulatory assist device. Because if you use them too late, they do not help. They have to be used early. The IBP, if it has to be used, it has to be used early enough. We should not wait till the patient is actually going to just, go. There is no chance left. We have to give them a chance. The heart has to be given a chance to recover, and IBP should be used early, or if you are using VA ECMO or whatever device we are using, it should be used early. And the other thing is what correlates best with outcome in these patients, these cardiac patients. What index is best? So the index that is best is not your cardiac output or your cardiac index or your blood pressure or your MAP or your wedge pressure. It is something known as cardiac power output. So for all of you who may not know, cardiac power output is actually MAP into cardiac output by 451. So you get a number which is equal to 1 in normal cases. It is actually the energy that is being delivered by the heart, the work or the energy being done by the heart. So I repeat, it is MAP into cardiac output by 451. Normally it is 1. And as it worsens, the heart condition worsens, it starts falling from 1. It goes to 0.8, 0.6, and 0.5. Below 0.5, the prognosis is really bad. So once it starts falling below 1, 0.8, 0.7, at somewhere 0.8 and below, one should start considering using IBP or whatever circulatory assist device one wants to use. And this correlates best with your outcome, the cardiac power output. So that's the point I wanted to make. And now I request Dr. Panja to comment if he has to make any comments.
Yeah. Thank you, Dr. Topes, Dr. Dev Kamal, Dr. Ayan, for being part of this discussion. I think hopefully this discussion as well as interaction was an excellent one, because this was a challenging case, and I hope there are other areas what we have discussed. And lastly, in your comment also, we have there are right now the cell pulse, particularly when you have mentioned earlier, when we used to practice about 20 years before about the cell pulse, it was almost 99.99% patient, those who actually came with real cell pulse poisoning, they used to die. But after this mechanical circulatory system, or particularly the VA ECMO has changed this scenario right now, there are good number of patients who survive this. And definitely there are scope for this particular therapy. But definitely being an intensivist as well as working in an intensive care, we should manage in the initial part, as well as we should know when we should actually involve the cardiology colleagues, as well as what are the other treatment options, so that the patient can get the best outcome from our treatment as well as our medical science. So that is the thing what I want to just comment. And in case any comments from Dr. Ayan, I think if Dr. Ayan is there, he can pass some comments, because he's
I think
managing.
you hit it on the nail, sir. So if you have to transition to mechanical circulatory support, it has to be early. Even in our practice, we used to do a lot of inotrope before, and then gradually put on mechanical circulatory support by the time where we have already lost the game, so or lose the patient. So it's important to transition early to mechanical circulatory support. And one thing to discuss between CentriMag and ECMO. So if you have a reversible cause of cardiomyopathy, I think ECMO is probably a better form of mechanical circulatory support. But if in this case, which is look at more durable form of CentriMag, because you can people who've been on CentriMax for up to a year. So that could be the basic difference. It depends on the strategy you have for this patient.
Oh, okay. Thank you. It's up to Dr. Tapit. Any comments and your last conclusion?
No, I think that was wonderful. Thanks to all of you. And there are no questions, I think. So I think we'll close the session. Thank you, Dr. Panja, sir. Thank you very much. Thank you, Dev.
Thank you, sir.
Okay, thank you, Dr. Tapit.
Thank you.